do. Let's have a conversation about ensuring this growing federal program returns to focusing its benefits on the patients it was supposed to serve. I was also asked to give a brief update on important nutrition legislation, knowing of NHCOA's leadership and having Dr. Cruz be on the board of the National Association of Nutrition and Aging Service Programs. The most recent development in that space, the House Appropriations Committee did pass its funding bill for Labor, Department of Health and Human Services. It included, and I use the word discreetly, a small $3 million increase for the Older Americans Act nutrition program, or as you may know it as Meals on Wheels. In this environment, you look past how small something is and just work to make it bigger. That's all our work, and to get the Senate to build on that. We continue to be stalled trying to get the Older Americans Act reauthorization, with its largest program being the nutrition program. The action has to begin with the Senate, with a bill we all support and want to see get passed. We continue to advocate for the passage of legislation to extend medical nutrition therapy under Medicare, which is only now available for people with diabetes and kidney disease. The bill pending would extend it to cover cancer, malnutrition, heart disease, and more. And finally, in an area where NHCOA is also involved as an active member of the Defeat Malnutrition Today coalition, a recent rule from the Centers for Medicare and Medicaid Services calling for the first ever malnutrition care score to be mandatory. This will require hospitals to screen patients for malnutrition as well as diagnose, treat, and plan a post discharge. So, nutrition is the bridge to better health. It deserves to be fully funded, especially those programs which help older Americans in need. Thank you very much.
Thank you, Mr. Blancato. Before we begin, allow me to provide context for today's discussion. The 340B drug pricing program was created more than 30 years ago with a clear purpose: to help safety net providers stretch limited resources and expand care for low income and uninsured patients. For many communities, such as the Latino older adults, that mission is still critically important. This was not an issue that I personally was aware of myself until I started working with NHCOA on this very project. I live in Kansas City, Kansas, and work across the state in very rural areas. I asked some of my friends and colleagues in rural Southeast Kansas if they knew about this issue because I would be facilitating a conversation today. And their response was 340B program was designed to be an excellent program. And when it works, it is. But when it doesn't, it does a lot of harm. So today we're here because there is mounting evidence that the program has drifted away from its original intent, as my colleagues who work in this area see on a daily basis. The Congressional Budget Office found that the 340B drug purchases have grown dramatically from 6.6 billion in 2010 to nearly 44 billion in 2021, raising important questions about what's driving that growth, and most importantly, if patients are the ones benefiting from it. Evidence suggests that they're not. There is a fundamental challenge of accountability. There is no consistent requirement for covered entities to demonstrate how those discounts are being used, or whether they're actually lowering costs for the patients the program was designed to serve. We're also seeing evidence that the current structure is creating unintended incentives. That gap in accountability encourages healthcare entities to prescribe medications at higher costs, such that profits may be captured in ways that don't necessarily translate into better access or affordability for patients. From an equity standpoint, this conversation is especially urgent. Older Hispanic adults and other older adults often face higher rates of chronic conditions like diabetes and asthma. Many who should be benefiting from 340B discounts still struggle with high out-of-pocket costs. When savings don't reach patients, these disparities can become much larger. While the 340B program was designed to support safety net providers, its evolution, particularly through hospital consolidation and the widespread use of contract pharmacies, has led to concerning growth patterns that dilute accountability and weaken alignment with the areas that see the greatest patient need, like we see in rural Kansas. Today's discussion is about solutions. How can lawmakers restore the program's integrity, strengthen transparency and oversight, and ensure the 340B once again centers on patients, centers on you, especially those most at risk of being left behind? To help us unpack these issues, I'm joined by two leading voices in this space. Thomas Johnson, Executive Director of Alliance to Save America's 340B, and Jeanette Contreras, founder of the Organization for Latino Health Advocacy. I look forward to a thoughtful and solution-oriented conversation with both of you. To begin with, will you each please take a few minutes to introduce yourselves and talk a little bit about your organizations and any points that you want to make sure that the audience hears?
Thank you. Okay, so it's my honor to go first. I'd like to take this opportunity to introduce everybody to our organization. We call it OLHA, Organization for Latino Health Advocacy. I founded the organization a year and a half ago, so that's why we're very new, but it was born out of the need for a consumer health advocacy organization to advocate on behalf of Latinos and issues that are important to the Latino community, as well as communities, other medically underserved communities as well. So we have 5 policy pillar areas that we work in to kind of try to guide the work that we do, and one of them is women's health, immigrant health, chronic disease prevention, uh, the social determinants of health, and access to quality care. And so this issue, 340B, really does touch on many of those, and we'll talk a little bit more about what we've been doing to work on this issue, and we look forward to engaging in the conversation. Thank you.
And I'm Thomas Johnson. I'm Executive Director of ASAP 340B, as we call it. We don't use a long name too much. But we've been around for a little over 3 years, almost 3.5 years. And we're a coalition of 47 national organizations that are seeking reforms to the nation's 340B program. Jeanette's organization is a member of our coalition. NHCOA is a member of our coalition. The National Hispanic Nurses Association is a member of our coalition. And we have probably about a third of our groups that are devoted to issues affecting brown and black people in the United States. The 340B program is supposed to be a program that helps the underserved by making sure the covered entities are able to get prescription drugs for outpatients at a discount. And what we've been talking about, and the reason why we've come together, is that increasingly we see patterns of that not happening. But this program has turned into a program where large corporate entities, be it hospital systems or PBMs, are actually profiting off of this program, and the benefits for this program increasingly are not going to the underserved.
Thank you both. So to begin, how should the 340B program be improving accessibility and health outcomes for older Hispanic patients managing chronic conditions?
Okay, well, I guess I'll go next. So as we were looking into this issue, of course, we want to focus on issues that what I call consumer health issues, are kind of like all issues that touch a person's out-of-pocket costs. So our seniors, our Medicare beneficiaries, are really familiar with, the high out-of-pocket costs that they face at the pharmacy counter. What we were looking at in our research is we found that there was a recent Millman report that found that Medicare beneficiaries were charged as much as 5 times more at 5 times more at 340B eligible entities than at non 340B eligible entities. So when we talk about 340B eligible entities, we talk about disproportionate share hospitals, hospitals that are supposed to be providing to qualify, a certain percentage of the care that they provide goes to charity care or low-income communities. And so what we found is that their 340B hospitals are almost like the worst actors in the whole healthcare system, because they're using the 340B program, it's intended to, but then they're charging the patient, especially Medicare beneficiaries, instead of the Medicare cost, right, charging them 5 times the list price of the drug that they're getting at a discount. And so, these kinds of actions, we can't really quantify as much as we'd like to. So part of the work that we're doing is to call for reform across the board, to give HRSA the authority to be able to, rein in some of the bad actors, do some auditing, and just force the eligible entities to report, to do better reporting on what they're doing with the profits that they're making off of these discounts. And so, in an ideal world, I almost feel like we could just see that the Medicare patients would be, getting that discount drug at the discount price, right? Or they would get their prescription medications at the 340B discount price, and then let the hospital sell the rest of the drugs at the regular price. That's fine, but at least pass those discounts on to those that should be eligible.
Yeah, I would just add, there are probably 4 areas that I would speak to with regards to this question. Jet just talked about the affordability issue. When it comes to patients, what that means is that, drugs that you normally get under this program, like insulin, drugs like those that are in the oncology space, um, the discount on those drugs do not go to the patient. What they're doing is they are going to these large corporate entities, and they're actually profiting off of this program for a program that's supposed to be a discount program, not a profit center for these entities. Senator Bill Cassidy, in his report last year, talked about the fact that 340B revenue is showing up at meetings where they're talking about earnings. Okay, what's not being talked about is how patients are profiting or benefiting from this program. Specifically, this money could be used, if it's used correctly, to fund wraparound services that reach patients directly. Services such as bilingual education, diabetes education, medical translation, all those types of things that affect patients directly. They could be funded by 340B revenue. Unfortunately, what we have seen in a number of cases is that revenue is not used for patient care or even for patients. They are used to build new wings in hospitals. They have been used to pay for things like Super Bowl ads. They have been used to pay for things such as the salary of a football coach. Those things have nothing to do with healthcare, and patients are not going to benefit from those types of uses. 340B revenue can also be used to try and attract specialists in specialty care to covered entities, where attracting those types of physicians cost more. And so you have an area where you can provide more revenue to attract those individuals, because many in the Black and brown communities need that specialty care to deal with a number of the chronic conditions that they face on a daily basis. But once again, since there's no accountability for the dollars that are being used by hospital systems, and we can't even collect that data because it's not required for them to report on it, they are using these dollars literally for anything. And that is not in the best interest of the patient.
Thank you. Did you want to add
I
something?
was just
Go
gonna
ahead.
add, I was like, because we could just keep going on this, but the one thing I would add too is that an example of an eligible 340B entity is a federally qualified health center. So we all know community health centers, how they work, right? They see patients, they they participate in this program, but they actually do provide, that charity care. They do provide prescription drugs on a sliding scale to their patients. They track the dollars very meticulously, not just because of transparency, but because they are um, a grantee of HRSA. And so as a grantee, they follow different guidelines, and the other eligible 340B entities don't do a lot of that reporting, and we don't have a lot of that transparency in how they're managing the program.
Thank you. So specifically for Thomas, can you provide some clear examples of misalignment between the program's original intent to serve vulnerable populations and the reality of patients' experience at the pharmacy counter? And particularly if you have any related to the Latino community, that would be fantastic if you could share those with us.
Sure. I'll talk about two specific things. Number one, the Government Accountability Office showed that over half of surveyed 340B hospitals do not offer discounted prices to low-income uninsured patients at their contract pharmacies. Over half. Compare that with the fact that hospital systems and retail pharmacy systems split a profit that averages 72% on those medications. So once again, we are talking about a program that is designed to serve patients, but hospital systems and PBMs are actually the ones that are making money off of this program. And they're making a lot of money off of this program. In addition, the JAMA Healthcare Forum really tracked this issue about contract pharmacies. I think that, when we see efforts to try and make sure that people have access to medicine, you see a lot of efforts to try and expand and make it almost, a quest to say that every contract pharmacy should be eligible for the 340B program. This is what's happening in reality. In reality, there are now deserts in terms of pharmacy that are in many Black and brown communities. Meanwhile, in the affluent communities, 340B discounts, in terms of their presence in affluent communities, have grown by 30%. So the trend is actually they are decreasing the number of facilities in underserved areas, and they are increasing the number of facilities, usually called child sites, in affluent areas. And that trend continues. So this isn't something that, certain interests have come up with. This is actually a study done by physicians who have tracked this issue regarding contract pharmacy. Our position as a coalition is that those contract pharmacies need to be located where the underserved patients are located. And they are the ones that should be getting the 340B discount, and not these affluent areas where the only advantage that's taking place is that hospital systems and PBMs are making more money off of those patients.
So I did my homework to prepare for this. Thank you, Christine Perez, for sharing information with me. But Thomas, I think you have some material that talks specifically about a cancer patient.
Yeah.
Can you kind of walk us through what that looked like? Because I think for me, that made this issue so concrete.
Yeah, and there are multiple stories like this. But there was one cancer patient in particular who the cost of the drug acquired by the hospital within the program, the actual cost from the 340 discount was $2,700. The hospital then turned around and billed Medicaid $22,700. Okay? Medicaid paid $10,000 for that drug to the hospital. And the hospital still turned around and billed the patient $2,500. Now, you tell me that this is supposed to happen under the 340B program. It's not. But because there's a lack of clarity in the statute, that is why we are seeking as a coalition to try and get reforms to this program so that these types of instances do not happen in the future.
Thank you. I think that example really makes this hit home for a lot of people. So thank you for sharing that. And thank you, Christine, for bringing that to my attention. So this conversation has highlighted concerns around transparency and how 340B savings flow through the system. So how does this lack of transparency impact Latino communities that already face significant barriers in accessing and affording care?
Yeah, so HRSA, like I mentioned, HRSA has grantees that they, like Brian White, HIV care, HIV/AIDS clinics, blood transfusion centers, FQHCs, grantees that they have great authority over. There's regulation there that stipulates how they can manage these programs and require reporting. And so they need more authority. They need better, I would say, statute to be able to regulate the 340B entities so that we can address, these egregious behaviors so that we can look at the data, right? We don't have even data on, what the entities are doing with the profits. We talk about how the contract pharmacies and the child sites are moved to wealthier neighborhoods, and that, of course, the incentive there is to sell more drugs so that they're making bigger profits. Because then if they're going to go to a low-income community and they're going to sell it at a discounted rate, they're not going to rake in the profits, right? So there's no financial incentive for them to go into low-income communities, but that's not the intent of the program. The intent of the program was for them to use that discount, yes, to, help pay the light bill, or, other things to maybe help pay for other, wraparound services. That'd be great. But what we're finding is that there's just so much, I almost want to say corruption, just in how these funds are being used. No, that's a strong word, but it's like if it looks like a duck, it quacks like a duck. So um, so that's why we really took an interest in this issue. It's a consumer health issue. We want to make sure that patients are seeing the discount, that discount is getting to them. We want to make sure that the funds are used as really a health equity tool, right? If we look at that angle, it could be. If we're using it as, we're always saying that the hospitals need to make a business case for keeping their most vulnerable populations healthy. Well, the business case is theirs. They're going to have less, visits to the emergency room if they're going to take care of the population, so that we avoid those unnecessary readmissions. If we avoid those emergency room visits, the hospitals, everybody would be better off, right? The community would be healthier. The system would have fewer expenses or high expenses if it reinvested those monies, those profits, to providing community health workers to go and help their communities. If they did, after hours clinics in the communities, if they had a mobile van, I mean, certain things we know, what evidence-based practices work in terms of public health to improve health outcomes in communities, but there's never any money to pay for it. Well, here's a big pot of money that we can use to pay for these kinds of things that would really improve health outcomes in our medically underserved communities. be it rural communities, Latino communities, super urban places, food deserts. I mean, there's an opportunity if we can get some accountability around this and we can give HRSA the authorities that it needs, then, we could probably turn this program around back to its original intent.
There's a reason why transparency is a key, if not really almost the key issue with regards to 340B reform. This is what you have to understand about the data that we're able to get now of the spending in the program by covered entities. 13% of those dollars are reported on in the way they should be reported on by covered entities that are not hospital systems. So we're talking about clinics and other types of entities. Okay? They report on their revenue and they report on what they spend those dollars on as HRSA grantees under a completely different statute. 87% of the dollars spent in the program are spent by hospital systems, yet they do not have to report on the revenue and what they're spending those dollars on. So you have to understand, if we're going to get a real view of what's happening with regards to this program and what those dollars are being spent on, we can't get that view if we can only see 13% of those reported dollars. You cannot get any type of perspective. And so, what the hospital community essentially is saying to us is trust us. This is what we're doing. Now, you all are in health policy. This is the second largest prescription drug discount program in the country, soon to be the largest. And they want to tell us, trust us on 87% of the dollars spent in this program. I think patients, consumers, and others under this program deserve far more than that. And in 2 or 3 years, this is going to be the largest prescription drug discount program in the country. It's going to pass Medicare Part D. And to say that we don't have a right to know basic information that clinics and others are providing, I think that, that's a very arrogant take. That's just my personal opinion.
Thank you. So how are trends like hospital consolidation and the expansion of contract pharmacy networks changing where 340B savings go? And what does that mean for patients who rely on these programs?
I think, one of the biggest issues here is that, I'll give you an example. Of the top 10 drugs in the program, 5 of them are in the oncology space. And one of our members, the Community Oncology Alliance, has done a lot of really great work in this space, just kind of tracking impact and tracking how covered entities have an incentive, especially hospital systems, since they don't have to report the data. They have an incentive to use more expensive drugs under this program because they will profit more because they can spread the price at a greater amount, and that will bring back more money to them. That is not necessarily going to be in the best interest of a patient. So if you have that incentive helps them not only profit more, but it also encourages them to acquire other entities in the program and also to extend that 340B discount, quote unquote discount, to other entities that they can acquire.
Mhm.
So now you've created an incentive for these hospital systems to not only acquire other entities, but also extend that benefit, whether it is in an underserved area or not, and make that acquisition more profitable. And so, really, that's the issue with regards to those incentives. We don't think that type of incentive should exist in the program. Again, we think that this program should really have its mission, going back to the original intent of trying to serve the underserved.
Yeah, and I want to add that, because we only have data that we can look at from the outside, for example, we see that the percentage of charity care that non 340B hospitals provide is a lot greater than what actual 340B hospitals provide, right? So we know that they're not providing their fair share of charity care, but yet they're taking advantage of these 340B discounts that the other hospitals are not. So there should be a way to make it that, if you're a 340B hospital or entity, that you should be providing a minimum amount of charity care, or if not a percentage of that, going toward, the communities that you serve, your medically underserved communities.
And then, Jeanette, staying with you, there is an increasing discussion around structural reforms. How could a shift towards a rebate based 340B model improve transparency and ensure savings are more directly tied to patient benefit and better target support to underserved populations?
Yeah, so a rebate model is basically based on reimbursement, right? So you're going to have the the patient, see the patient, give the medication, and then get reimbursed for it. So you're going to pay full price first and then get reimbursed for the difference, the discount. Um, the rebate models are um, used successfully across the federal government and other programs. For the 340B, well, right now HRSA has a 340B pilot program that's designed to be used for the 10 drugs that are being included in the 2026 IRA drug list, the drug negotiation program. So all of these, I'm trying to not use acronyms, sorry. And so, um, it's definitely a step in the right direction that, we're able to look at the data behind, how this is operating. It's going to give us a peek into how, at least with these 10 drugs, the rebate model can help to um, incentivize and if not, avoid some of that duplicate discounts, some of that improper usage, and to hopefully ultimately get that discount to the patient, right? Because then there it's linked to a direct reimbursement.
Thank you. Thomas, did you have anything to add on that? Okay. If we could come back a year from now and say the 340B program is truly working for Hispanic patients, especially our older adults managing chronic conditions, what would have changed and what would success look like in their everyday lives?
I point to a number of things. Um, Number one, I think that if we had the ideal program, and the program went back to its roots, patients would be able to see and feel a discount um, when they would get drugs from covered entities, especially hospital systems. In a lot of cases, I would say probably in most cases, patients aren't even aware that that covered entity is a 340B provider. Now, I have actually heard there's one of our coalition members recently came out with a proposal that maybe every covered entity should be required to either post or provide information to a patient that they are indeed a 340B provider. I don't think that's actually a bad idea. I think that's very consumer friendly. But if we're able to make that happen, then I think that patients will be able to start to see that benefit eventually come to them. Clearly, transparency making sure that hospital systems provide the same data on revenue and spending that all HRSA grantees have to provide. If we're able to see that, then we can really get our hands wrapped around, you know, the benefits of this program, the need for this program, how it's benefiting those wraparound services and other types of services that I talked about. I also think that this would have an effect on some of these pharmacy deserts that we talked about with regards to the underserved, and making sure that that discount really stays in those areas where the underserved reside, so they don't have to, you know, we're talking about social determinants of health. They don't have to go someplace of great distance to a pharmacy to get that benefit. Um, you know, I think the clinical incentives will become more important over some of these corporate profits that hospital systems and PBMs are currently enjoying under the current system. And I think, you know, ultimately, just speaking with regards to community health centers, I think that they would be more powerful under this system to provide those services in communities where they know the patients that they're dealing with, including Hispanic communities. Um, you know, we want to make sure those community health centers are strong financially. 340B revenue is an important revenue source for them. They are doing the right thing in terms of reporting. You know, they should be rewarded for that.
Yeah, agree. Oh, can I follow?
Yeah,
no?
please.
Oh, okay.
Please.
We're doing like the wrap up, but I love that idea that, and I've heard that too, that we should post or, you know, have hospitals announce that they're a 340B entity. There's a lot of education that needs to happen on a consumer level, right? Folks don't even know that this prescription drug program exists. Um, you know, so if we had a way to, you know, let consumers know, hey, you know, these hospitals that provide, you know, care in your community are, you know, beneficiaries of this discount program, and you can be a beneficiary too, right? It's almost, if we just say it as like a benefit, you know, that people can have access to, it would be really helpful, right? Because then these people could get their prescription medication, especially our Medicare beneficiaries, you know, get that discount, get it on a sliding scale, you know, based on income. You know, there's other programs that work on that, you know, 200% or 150% of the federal poverty level, whatever it is in your state, right? There are those guidelines that make it easy to kind of identify what population, you know, would qualify for a discount, if not get something for free. And FQHCs do it with their patients. You know, they sit down, they get to know their communities. And sometimes these 340B hospitals will see a patient only once during an emergency. And it's like maybe episodic, you know, at best, but they're not really getting to know the patient like an FQHC is. And so I'm going to come back to my one thing I always talk about in terms of healthcare, is that if we make it a business case for hospitals to provide this charity care, to provide equitable access to care, because they have the funding to do it, they're going to have healthier communities. They're going to avoid hospital readmissions. They're going to avoid fatal, life-threatening, you know, conditions coming into their emergency rooms. They're going to avoid those expensive MRIs and CT scans. You know, if we can keep people healthy instead of waiting for them to end up in your emergency room, and that business case should be where we can use this 340B funding for.
I want to just add one other thing. The state of Minnesota now produces a report on 340B covered entities annually. They just released the second report. The first one came out last year. And one thing that really stood out, you know, I talk about, you know, these business and corporate issues. Clinics from 2024 to 2025 received about a 6% increase in revenue from the 340B program. Hospital systems received a 112% increase in revenue from 2024 to 2025 from this program. If that doesn't tell you something, that's a lens, I think, to the types of information that we're looking for and why transparency is so important to making sure that this program does what it's supposed to do.
So can I ask a follow-up question? There's no place for a consumer to go and look up if their hospital provider is a 340B.
You can go online. There's probably a maze to find that out. There are websites that have that. I know that the Pioneer Institute is one that actually lists all of the covered entities on their website. But I don't think that's something that necessarily all consumers are going to be able to relate to. I mean, people in Washington know the Pioneer Institute, but the average person does not know anything about or even heard the Pioneer Institute. So, so you know, that's why I think that proposal by Cancer Care, who's one of our coalition members, is really interesting because it puts it on that covered entity to at least say, we're a 340B covered entity. There are no issues with healthcare facilities posting their notice of privacy practices, which is required under HIPAA.
Mm-hmm.
Certainly, those facilities can provide the same information as to whether or not they're a 340B hospital, and many clinics actually do that.
Nice. So going back to the cancer patient example, and we're talking about if we're able to close these gaps. So that patient needed a drug that the hospital paid $2,700 for. They charged Medicaid $22,000. Medicaid paid $10,000, and then the hospital turned around and charged the patient $2,500.
Mm-hmm.
So if we're able to close the gap, how might that story change for that patient?
I think in a couple of areas. Number one, I think the billing from that entity to the payer, Medicaid, would be more accurate in terms of recovering the difference between the discount and the price of the drug, not 4 to 5 times the price of the drug.
Mm-hmm.
Okay, and understand when we are in an era where Medicaid spending just went through a legislative process where those resources are now going to become more scarce for a lot of entities. So now isn't the time for us to bill artificially 4 to 5 times, much less sometimes 10, the cost of a drug. Mm-hmm. Okay? Because those resources are going to become more scarce. We need to be more accurate in the billing that takes place there. And clearly, one thing I didn't say about that patient is that when they switched to a non-340B hospital, they were not billed. Just think about that.
Yes. So thank you both. I think that is a stark difference in patients' lives. I know I personally, I'm not sure if my mom was treated at a 340B provider or not, but I know that when she went to Medicaid, she has multiple sclerosis. Her insurance under her employer, her private insurance, her medication for her MS to slow the progression was about $200 a month. When she went to Medicaid, it ended up being $2,000, and she's living on Social Security, so fixed income. And she had to herself taper off of her medication with the recommendation of her doctor, um, because she could no longer afford it. It was not a sustainable price for her. And we have seen changes in my mom's physical abilities and cognitive abilities since she has decreased on her medication. So this is not just a financial thing, but for a lot of our patients, it's a life-threatening issue if patients are foregoing their medication in lieu of being able to pay for it. So thank you again, Mr. Johnson and Mrs. Contreras, for joining us today and providing such valuable expertise and knowledge about the 340B program. I'd like to open up the discussion to questions from the audience. Yes.
Good afternoon. Thank you, Thomas and Jeanette, for being here. I'm Alexis Walker from ASI. Let me talk a little bit about pharmacy deserts. And I'm thinking of like overall healthcare deserts and how the 340B program has allowed the covered non-hospital covered entities, or I'm sorry, non-like DISH and QHC covered entities, so hospital covered entities, to open up child sites in more affluent areas and then close down their sites that were in places that or Black and Brown communities or places that offer charity care. How do we address that issue with the B program, where they opened up a child site elsewhere and then closed down the site in the lower income?
Well, part of our policy principles on our, you can find them on our website at www.asap340b.org, addresses that specific issue as it relates to child sites. And what we want to try and do is make sure that sites that are eligible for this discount are in certain statistical areas that are served by the main site that's in that underserved area. The late Representative McEachin actually addressed this with regards to the Bon Secours health system in Richmond, Virginia, where that indeed was happening. That was a pattern. They closed down some of their facilities at the main site in Richmond, and then they extended um, uh, those facilities in affluent areas and then applied the discount to those affluent areas outside of that metropolitan statistical area. So, one of our principles is that we want to try and correct that and make sure that the discount stays within, those metropolitan statistical areas and not in those affluent areas.
I think it's interesting to think, do we need legislative language to fix that specific issue, or would HRSA's just need extended authority? Like, so either way, we need legislation, right? So that HRSA has authority to then maybe put out a proposed rule that's going to then change that guideline to disallow that from happening. But either way, we're at the point where we need legislative action. It's not something that we can just do like through the executive branch.
Yeah.
Other questions?
Yeah.
Yeah.
How do you anticipate this program changing if and when it's transferred from HRSA to CMS as it's been discussed?
It's hard to say. CMS really, this is probably more my opinion than anything. CMS really has been, because Medicaid is a federal state program, I think they've been really kind of focused on working primarily with states and their needs, as it relates to Medicaid. Because states will often offer additional rules for the Medicaid programs that go beyond what the federal rules are. I know that there are some concerns from the hospital community about what that might mean with regards to 340B. Our approach as a coalition is that, we think that there should be a comprehensive federal solution and that we shouldn't have different rules in, different states for the program. CMS has obviously got more resources than HRSA, and I think to speak to Jet's point, that's needed for such a large program that actually I think now is about $81 billion as of 2025. So, those are just kind of some of the thoughts there with regards to what I think CMS could do if they had the authority.
CMS manages the claims data, so they would be the ones who like sort of really have that pinpoint on the reimbursement.
Yes.
I'll ask a question. So is the reason why these hospitals are able to charge 5, 10, sometimes up to 10 times more because there's nothing in the statute that prohibits it, or is that, and is there anything that we could do even legislatively or just for Medicaid patients to stop that price gouging, for lack of a better term?
Yeah. No, that's the exact reason why that practice exists. And it's a practice that is known within the PBM community in terms of spread pricing. But in this case, because of the lack of clarity in the statute, they are taking it as far as they can. And so I think you have to have a legislative solution to address that. One thing that I would say that our coalition members agree on is that we don't necessarily think that it's wrong if you as a covered entity, let's say you get a drug from the 340B program. The average discount currently in the program is a 59% discount. Okay? If you want to bill a carrier, Medicaid, Medicare, private insurance, for the remainder of the amount, our coalition doesn't have an issue with that. Okay? But when you're talking 4, 5, 10 times the cost of a drug, I mean that's literally price gouging.
I have a question. Smoking cessation among older adults has been historically problematic. In other words, older adults have one of the highest smoking practices in the country. And as you know, smoking can lead to all kinds of chronic illnesses like cancer, etc. Might there be an opportunity to use 340B for a smoking cessation type of program?
No question about it. I mean, those are the type of wraparound services that I talked about, where 340B revenue could be used for. You know that it's going towards patient care, and it's not going into building a new wing, or a Super Bowl ad, or naming rights, or other types of things that clearly have nothing to do with healthcare.
Yes.
Yeah, so kind of bouncing off the kind of case problem that we were talking about earlier, when these hospitals are charging exorbitant amounts to Medicare, Medicaid, is there any, legislation that dictates they need to give a reasoning to any of this, or is it just purely the number and that's all that's being kind of reported?
I'm not aware that there is anything specific that says that they have to give a reason for the charge. Um, if there is, literally nobody is aware of that. But I'm not aware of anything specific that speaks to that concern.
Thank you.
How does this issue look like in rural communities? Is it similar or is it different?
No, it's very similar. So a lot of the rural hospitals are either HRSA grantees or federally qualified health centers that are placed in medically underserved communities. And so they often are following the rules because they're grantees. But one of, like, if you imagine like a St. Jude, this giant, hospital, it does have rural, outposts, like child sites and things like that. And so that's what it should be used for, right? To provide that care in medically underserved areas. So that's kind of what we see with rural.
Any other questions? Okay. Mr. Johnson and Ms. Contreras, we have a very diverse room. Some folks have shared that they are interns or fellows. And then we also have residents, community residents. So if you could give them a message, and you might have to give a couple different ones depending on the context that they're working in, but what are things that they can do at their level to make a change? Because I think sometimes with these big issues, particularly around health policy, folks feel like they're disenfranchised or not empowered to make changes. So if you have a takeaway message that you could share with folks today, that would be fantastic.
Well, for our seniors and Medicare beneficiaries, I always say that the best consumer health message I can say is review your bill before you pay it, and know that sometimes they'll send you a bill even though it's already been paid. So make sure that you check with your payer first before you pay the provider to make sure the insurance has paid it. In regards to 340B, I would also ask your provider if there is a discount available for the medication that you take, because there probably is. And if they have access to a coupon, sometimes your pharmacist might have one. It never hurts to ask for a coupon or if there is a discount that's available to you in your community. So it just depends on your medication.
Yeah, I would. I'd say two things. Number one, um, ask your hospital or clinic if they are a 340B provider. You have the right to know that. The second thing is, you know, I am. Well, I'm not going to say how old I am, but I'll tell you something. Groups like uh, um, National Hispanic Council on Aging, you know, your constituency is very strong. From what I see in terms of representatives, people representing you, they listen to you as constituents. So you need to raise this issue with your local constituents and with your local politicians and your national politicians. You know, I live in Maryland, you know, and there is a vote today, okay, on who's going to represent, you know, the different parties. I guarantee you that they are aware, more likely than not, of the 340B program. Okay, just from my travels over the last 3 years that I've been doing this, they are aware. But what they're not hearing, they're hearing from people like me, okay? What they're not hearing is from people like you. So you make it an issue for them to deal with, okay? And then they will talk to their federal counterparts, if you don't, and say, hey, we need to do something about the 340B program. They will listen to you.
So, in my other life, I also teach masters of public health students, and I teach public health law and policy. And I let them know, my students, that some of the strongest things that they can do is write letters and make phone calls. And you might think that someone's not reading them, but they sure are counting those letters and those phone calls and understanding what those topics are and where people are falling on them. This is the best way to get a hold of your uh, representatives and the people that are deciding these things for us. And so I really, really encourage you to get informed. If you want more information on this topic, NHCOA's Status of Hispanic Older Adults report that came out in 2025 has this topic in there with specific policy recommendations. Please also visit our speakers' organization websites if you're also not sure kind of what to say in your letter, but raise this. And it doesn't have to be a long letter. I've had some of my students write 3 sentences, right? Just get your points across to the people that are representing you. Do you have any closing remarks that you'd like to share?
Oh, yes, for the young people in our audience, we have a youth action network. So if you go to latinohealthadvocacy.org, you can sign up to receive information about our advocacy initiatives.
Yeah, I just say thank you for inviting me to speak before everyone. I like engaging with people about this issue. I've been involved in healthcare policy issues for over 30 years, Medicaid for probably about 20 of those 30 years. Um, this is an extremely important issue if we are going to really look at, making these drugs for outpatients more affordable for patients. It's very, very important that you speak up on it.
Well, thank you. And before we close our briefing, we invite you to join a growing movement of individuals dedicated to improving the lives of older adults, their families, and caregivers through our individual membership program. NHCOA has brochures about this program on our table outside. For just $25 a year, members get access to exclusive resources, educational workshops, advocacy tools, and bilingual information on health and aging, all while directly supporting NHCOA's mission to uplift and empower our community. To learn more or become a member today, again, please see one of the staff in the back for a brochure. And then a recording of today's briefing will be available on the NHCOA YouTube channel. We encourage all of you to follow NHCOA's social media channels. We have X, Facebook, and Instagram using @NHCOA for more information and news on upcoming events. Thank you and gracias for your time.